Hello everyone, I am Noemi Reguart. I'm a medical oncologist settled in Barcelona, Spain, in Hospital Clínic, and we are here at the European Lung Cancer Conference 2025 in the beautiful city of Paris. So ADCs is one of those technologies that, although it's chemotherapy, it has a different way of deliver the cytotoxic payload into the cell. So it's probably one of the most newest developments in the field of therapies in thoracic tumors. In lung cancer, it has been the use of ADCs, it has been lagged behind compared to other diseases such as hematological diseases. But we are seeing now the ADCs are being tested and explored in different settings. We do know that there is one approval in lung cancer with ADCs, which is trastuzumab deruxtecan, which is approved for patients with HER2 mutations. Beyond that, right now, we don't have that much approvals in the non-oncogenic addicted settings, but we are seeing right now here in the conference and during the last year that the ADCs are being explored in the first-line setting in combination with immunotherapy and also in the second-line therapy in those patients with oncogenic alterations after progression. So it's a field that it's going to change. It's going to, for sure, in the next 1 or 2 years, we are going to see more and more trials that are exchanging the chemotherapy by these specific ADCs. And for sure, one of the challenges is how we are going to approach the different toxicities with these drugs. These drugs have a really specific toxicity profile, which is very different to chemotherapy. It's very complex. It depends on the payload. It depends on the antibody you are using. It depends on the expression of the protein because, as you know, the ADCs bind to the protein on the cells. And sometimes these proteins are not only found in the tumor, they are also found in healthy tissues. So these ADCs sometimes are associated to a specific off-target toxicities depending on the expression of these proteins outside the tumor. So we will have to learn how to handle this safety. How can we integrate prophylactic measures to follow up on these patients? But we know that this is what we are doing in oncology. We're learning more with new drugs, new toxicity profiles, and we always find a way to mitigate these toxicities when we see that the drugs are providing benefit in the outcomes of our patients. I mentioned before, ADCs, it's novel technology. It's an antibody that has linker, and in those linker you bind the payload. So the way of thinking it's clever delivery of chemotherapy. So the antibody binds to the protein, which it has to be expressed on the tumor cell. And in there's an endocytosis, the delivery of the drug, and the killing of the cells. So one of the most important challenges with these ADCs is that the proteins, those proteins can be expressed of tumors. And that's what it's inducing the off-target toxicity. So toxicities that should not be there, but if the protein is not highly specific of the tumor, you can find them. Each antibody has its own specific toxicity that it's going to depend on different factors. It's going to depend on the stability of the payload, it depends on the protein of cell, it depends on the antibody, and it depends on the type of chemotherapy and the payload. So it's a learning curve. You have to remind that depending on the ADC you are looking at, you are going to have specific safety profile. It's completely different between the different antibodies. And the future is, if we have in the future, near future, we have these antibodies integrated in more tumor scenarios, lung cancer tumor scenarios, I think we'll have to learn how to handle this toxicity and prophylactic measures. This is very important, and this is something that we have learned. We have seen with the Cocoon trial, with the bispecific Mariposa trial, if you integrate this prophylaxis into patients, then you can mitigate the toxicity. So this is the future, and I'm sure with time, learning curves, we will be able to handle with this safety profile of the ADCs. I have to say that the king, it was the Mariposa, the overall survival of the Mariposa trial. So there were really nice presentations, but for sure this is one of the things that we were expecting more, because we know that there are several strategies that are being explored in the first line, and for sure in Asia this is very important because the rates of EGFR mutant patients are higher. So in there, we had osimertinib, standard of care. That was oral drug, 1 pill a day. It was very easily taken, and the safety profile was very good. And we had those overall survival, 38 months. So what we wanted, though, is to improve that. We always want to improve that. So improving that meant that we had to explore combination strategies, and there are several combination strategies that are being explored. One of them is combining these ADCs we were talking about. It's the tropion-lung-14. It's exploring ADCs with osimertinib. This trial is ongoing. Another strategy was the FLAURA-2 study, which was combining chemotherapy with the tyrosine kinase inhibitors. And then we had the Mariposa trial, which was a different type of drug, which is amivantamab, a bispecific anti-MET and anti-EGFR combined with osimertinib. This trial was positive. They combined it with lazertinib, This trial was positive, demonstrated an improvement in progression-free survival, a significant improvement, but we had only in preliminary data on the overall survival. So they had presented this year here in the European Lung Cancer Conference with longer follow-up, and I think it was 35% of events. Longer follow-up on overall survival, and although the median overall survival for amivantamab, lazertinib has not been reached, it is already a positive impact in overall survival, with curves that separate, they separate since the beginning, and the curves separate widely over the time. So it's the first study that demonstrates that another strategy beyond the tyrosine kinase, a combination strategy, can indeed improve overall survival in first line. It'll be very important, though. Amivantamab is associated with a higher rate of toxicities. It's a specific toxicity profile. So here in the conference, they have also presented the Cocoon trial, which is a way of integrating strategies to mitigate the toxicity of amivantamab. And with that, integrating this intensive prophylaxis regimen, mainly with the nails, with the skincare, mold, you see how the incidence of grade 3 adverse events decreased dramatically. So very important to individualize patients. We need to know which ones might benefit most from these strategies. And very, very important, learn how to integrate this prophylaxis to improve this toxicity profile of new therapies.